Today, my topic is rhinosinusitis, our update understanding. This topic is based on my observation because many of our residents or medical students ask about how to understand and diagnosis rhinosinusitis based on the new concept of a new EPOS 2020. As we already know, there is several changes of new concept from the EPOS 2012 into the EPOS 2020. Nowadays, the classification and diagnosing rhinosinusitis is not only based on the phenotype, but also with endotype, based on the pathomechanism or patient immunologic background, especially for severe and recurrent rhinosinusitis. So I want to try to make a more simple, step-by-step how to diagnose rhinosinusitis based on the new concept of EPOS 2020. Rhinosinusitis is defined as an inflammation of the nose and paranasal sinuses characterized by two or more symptoms, one of which should be either nasal blockage or nasal discharge anterior posterior, accompanied by additional complaint like facial pain or reduction of loss of smell. So if patient came with only facial pain or reduction of smell, we cannot diagnose as rhinosinusitis because there is no cardinal symptoms such as minimal one nasal blockage or secretions. After that, we can divide by acute less than 12 weeks and chronic more than 12 weeks. So, of course, we cannot diagnose only based on the symptoms. We have to confirm with physical examination, like nasal endoscopy, as from the EPOS. Minimal one symptoms from three signs: purulent secretion, or erythema or swelling in the middle meatus, or there is a nasal polyp in the middle meatus, so that we can diagnose as a rhinosinusitis. Nasal endoscopy up to date is still a gold standard to diagnose rhinosinusitis, not CT scan. So we do not perform CT scan at the patient first time patient came. We only perform the CT scan for the patient with high suspicion of complication of acute rhinosinusitis, recurrent acute rhinosinusitis, unilateral secondary CRS, or primary CRS after appropriate medical treatment, minimum 4 until 6 weeks. In acute rhinosinusitis, there are four phenotypes: acute viral rhinosinusitis, acute post-viral, acute bacterial, and acute recurrent rhinosinusitis. Why we have to differentiate all of these phenotypes? Because so far as we know that there are such extensive uses of antibiotics, especially for acute rhinosinusitis. Based on the pathophysiology, we already know that only limited cases will continue to bacterial infection. Most of the acute rhinosinusitis is only viral infection or post-viral infection. So that a lot of misuse or overuse usage of the antibiotic that's trigger the superbug bacteria. WHO already predict by 2050 there will be 10 million deaths because of the overuse of antibiotics, especially for acute rhinosinusitis. That's why we have to be very, very careful to choose and make a decision to give antibiotic to our patients, especially for acute rhinosinusitis. So EPOS already give us a guideline how to differentiate viral, acute post-viral, and acute bacterial. Maybe because of limitation of time, this will be speak by more detail for the next speaker, Dr. Febri. So I continue with the recurrent acute rhinosinusitis. Recurrent acute rhinosinusitis is one of the phenotype that quite unique because sometimes it's difficult for us to diagnose and difficult to make a conclusion because some patient with recurrent acute came to us with a normal endoscopic or normal CT scan, so that there is a guidelines give us how to make a diagnosis. Minimal 4 episodes per year right now, with acute bacterial patients, and each episode should each episode should has symptoms or sign acute rhinitis that fail to improve in 10 days or have a double sickening. The pathophysiology of a recurrent acute rhinosinusitis, some literature mentioned that about the anatomical variation maybe have a role for recurrent acute, and also immunodeficiencies, especially IgA deficient or comorbid allergic rhinitis. So we have to be very detailed in anamnesis and make a endoscopic examination and learn from the CT scan. And some experts suggest that we can perform the CT scan and to not only to find the disease in the sinus, but also to try to find out what kind of the anatomical variation that could contribute to the recurrent rhinosinusitis. How the management, after maximal medical treatment, but in some patients, the frequency and severity of acute bacterial and decrease a burden of quality of life and productive impairment make the patient of RARS almost the same with CRS. So that some experts suggest us to give the perform the surgery. And when the surgery is suggested to patient with RARS, if we already confirmation at least 1 episode acute bacteria using objective measure, minimal nasal endoscopy and CT scan, and share decision making between patient and clinician regarding surgical treatment, either of failed treatment with topical nasal intrasteroid and significant reduction in daily productivity to RARS. So, jadi beberapa ahli memperbolehkan kita untuk melakukan operasi FAST pada RARS dengan syarat kita sudah menegakkan diagnosis, sudah mengikuti pasien minimal setahun, dan melihat memang ada kelainan variasi anatomi. Dan kita boleh melakukan langsung CT scan karena tujuan CT scan tidak untuk mencari perselubungan pada pasien. Sehingga kita boleh melakukan FAST pada pasien-pasien dengan CT scan yang normal, tapi lebih untuk mencari faktor predisposisi yaitu variasi anatomi. What kind of surgical technique they recommend for the RARS? Limited surgery with maxilla, limited to maxilla and ethmoid, without septoplasty for patient without septum deviation, and limited surgery maxilla and ethmoid with patient for septoplasty. We perform also with septoplasty for patient with septal deviations. This is study which revealed that the result there is a significant improvement of quality of life patient with RARS who undergone the surgery compared with medical treatment. Now we can go to CRS. As we know that in EPOS 2020 is classified into primary and secondary. Primary is based on the pathophysiology is intrinsic mucosal inflammation. And so the ventilation and dry net concept is already left behind because maybe it has a role, but it's only limited role. So it classify into anatomic distribution, localized, unilateral, or diffuse bilateral. Some of us may be misinterpreted because not all localized is not identical with unilateral. Maybe in some patient has a localized, but in both sides of the patient. So it is important for us to understand the pathophysiology, even though the patient, not for other patient, but in one patient in both sides maybe have the different pathophysiology. And based on the pathophysiology, it's divided into type 2 and non-type 2. Type 2, unilateral, could be allergic fungal, and non-type 2, isolated sinusitis. And diffuse sinusitis could be divided into type 2 and non-type 2. In type 2, it's CRS with nasal polyp, allergic fungal, or CCAD, and non-type 2 is non-eosinophilic rhinosinusitis. This is the slide from Professor Richard Harvey, but I really love this slide. In 1980s, we still think that infection and obstruction is the main cause of rhinosinusitis, chronic rhinosinusitis. But in 1990s, we start to think that maybe there is a role of inflammation of the chronic rhinosinusitis. But in 20th century, we already know and understand that inflammation is the most etiology of rhinosinusitis. So what kind of the pathophysiology in type 2 inflammation? This type 2 is usually IgE mediated, so it will have interleukin 5, T helper 2, eosinophil, ACP, or IgE dominant. So when we try to diagnose, we can check the biomarker which lead to this cytokine or interleukin. In contrast, in non-type 2 inflammation, with interleukin 1, 6, 17, TNF alpha, interferon gamma, and tumor growth factor is some predominant in non-type 2. And according many literatures, in non-type 2, rare patients have a lower possibility of recurrence compared with type 2. In some cases, there are also a mixed inflammation, non-type 2 with type 2, and some in these cases makes the rhinosinusitis more intractable and difficult to treat, because in non-type 2 sometimes patient has no response with a steroid. So how can we diagnose the type 2 rhinosinusitis or non-type 2? Step 1, we have to define endotyping by check the clinical phenotype and molecular phenotype. Clinical phenotype based on the anamnesis or history. Usually the patient with type 2 has anosmia and history of skin prick test positive or allergy, and also concomitant late onset of asthma and recurrent CRS after surgery. This is the most frequent symptoms in type 2 rhinosinusitis. As we can see that in type 2, predominant symptom is anosmia or hyposmia. Compared with non-type 2, the nasal obstruction is the most prevalent. So, and then we try to check the biomarker. There are several literature suggest that to check the three majority biomarker: blood eosinophilia, total serum IgE, and tissue eosinophilia. This is Professor Becker suggests that the cutoff point of blood eosinophilia is 300, and the cutoff point total IgE is 150. How we count the blood eosinophilia? Usually, menurut saya ini pemeriksaan yang sangat simpel, dan saya rasa semua teman sejawat bisa melakukan pemeriksaan ini hanya dengan memeriksa darah lengkap. Kita melihat persentase dari ini nggak jalan. Persentase dari eosinofil. Kalau Jepang menggunakan kriteria persen, jadi 5%, sedangkan kalau pada misalnya Eropa atau EPOS menggunakan amount atau jumlah dari eosinofil. Di sini kita lihat persentasenya 8,7. Saya nggak bisa lihat. Sorry. Ya, jadi persentasenya 5,7% dikali dengan 8.000 jumlah leukosit total 8.570. Kita mendapatkan jumlah 488. Ini lebih besar dari cut off point 300. Jadi kita bisa mencurigai bahwa pasien ini memiliki blood eosinophilia dan mungkin memiliki tipe 2 inflamasi. Enggak bisa di next slide. Dan kemudian, and then we check the tissue eosinophilia by, usually I perform the local reduction polypectomy at the patient first time came. Dr. Dani has teach me when I was resident to perform the local polypectomy. Bisa digerakin, bisa dibantu di sini aja yang slide. Polypectomy. I always perform the local polypectomy at the first time patient came. Belum, terus. Ya, nih, ya. Bisa di play ya? Bisa dari sana aja deh, slide-nya susah. Oh ya, oke. This is one of the massive polyps. The first time patient came, I performed the local polypectomy, and after the polypectomy, the patient is very happy because the patient can read again. This has a purpose. Beside for the diagnosis from the histopathologist diagnosis to get a tissue eosinophilia, and also I want to reduce nasal obstruction meanwhile receiving appropriate medical treatment, and facilitating topical steroid for maximal penetration and absorption. As we know that the primary CRS, we perform the surgery after the period of maximal medical treatment in EPOS 12 weeks, and some literature suggests about 4 until 6 weeks. And the diagnosis was made from histopathologist. I think it's also available in almost all of us, because in the hospital who has the histopathologist, they will help us to count the eosinophil count. In this patient, for example, there is 35 until 40 in per high power field, and cutoff point from EPOS is 10 for high power field. So we can suggest that we can suspect that this patient might have type 2 inflammations. Okay. So there are several literature suggest that surgical technique is different from type 2 with non-type 2. In type 2, many literature suggest, for example, in EPOS or Professor Becker suggests for full house fast or extended fast for in open wide cavity for installation of the irrigation after the surgery. But we have learned a lot from Professor Amin Jaffer, the presentation, that sometimes it will not help the patient, even though we already make a wide open cavity. Okay. Next. Okay. Because there is an algorithm for, especially for type 2 or intractable. First, patient has to receive medical, because this the etiology is inflammation. We give the anti-inflammation medical treatment and then continue with surgery. And after surgery, if it fails, then we continue with surgery. After surgery, if it fails, we go back again to the medical treatment, even with maybe with steroid high dose or nasal steroid irrigation. Next. This is high, for example, steroid high dose. Next. Or steroid irrigation. This is a study from Professor Richard Harvey performed the surgery in cadaver and compared the unsurgeon cadaver with surgeon cadaver, and there is a good penetration of the nasal irrigation using the high pressure, high volume irrigation into the nasal cavity using this technique after the surgery. Slide. Okay, this is one of my patients, a very intractable, difficult to treat rhinosinusitis with severe asthma. Patient came with very high eosinophil, 1,254, and slide. He has also high eosinophil count in tissue or polyps. Slide. And I performed the extensive surgery, open wide cavity, and for the sinus, extensive surgery, I perform modified Lothrop or draft 3. We can, yang di sebelahnya. Yeah, I perform a modified Lothrop or draft 3, and we can see that all the sinus frontal cavity is full with the polyps, and also the mucosa is polypoid. And we can see after surgery that the open wide cavity. But as Professor Amin Jaffer said, that even though we already performed extensive surgery, then it will still recur for severe intractable patients. Slide. This is 3 months after surgery video. We can see that 3 months after surgery, the osteum is start to narrowing and the nasal mucosa is very thick. Videonya mohon dijalankan. Videonya belum jalan. Ya, dipercepat. And we can see that in the frontal, even though I open it widely in the frontal sinus, we can see that only small osteum and cover with all the polyps. Okay, slide. Okay. So therapeutic concept that this will answer much of college questions. Jadi banyak sekali teman sejawat yang bertanya, kenapa sih kita harus memberikan maksimal medikamentosa dulu pada kasus RSK primer? Kenapa nggak kita langsung operasi saja? Toh ujung-ujungnya nanti akan kita operasi juga. Kadang-kadang pasien datang dari luar kota, pengen cepat-cepat dioperasi, pengen nafasnya relief kembali gitu ya. Tapi tadi kasus yang tadi bisa menjelaskan bahwa there is no need to rush to perform the surgery because for severe or intractable, even though we already open wide cavity, there is still a recurrence of the polyps. So we have, meanwhile we give the appropriate medical treatment, we can search the pathophysiology of the patient and try to combat the pathophysiology. And we can inform consent to the patient that surgery is not intended to remove the polyps permanently. It's like, but the purpose is effectively delivering anti-inflammatory to the sinus cavity. So it will prevent the high expectation of the patient. We have to make a close relationship to the patient. Kita harus jelaskan bahwa ini mungkin akan memerlukan kontrol yang jangka panjang, ya, long-term follow-up, close observation. If the patient came with another recurrence, then we have to try to another therapy. Slide. Okay, this is allergic fungal. Allergic fungal is a variant of type 2. How to diagnose? There is a criteria from Ben and Kuhn. We can see that patient must have type 1 hypersensitivity, nasal polyp, characteristic CT findings, eosinophilic mucin without invasion, and invasive fungal stain. Usually we check the mucin and if there is any high eosinophilia with a high fungal hyphae, then we can also see the CT scan with hyperattenuation and bone erosion. Then we suspect that it might be a fungal invasion, allergic fungal rhinosinusitis. Slide. How about CCAD? Slide. CCAD is the polypoid changes in early stage, usually in the anterior superior compartment allergic disease. Usually the inflammation occurs in midline. So usually we see that there is a polypoid changes in the middle turbinate, superior turbinate, and posterior nasal septum. Slide. How about the management? Usually we perform the medical management 6 to until 12 weeks, allergy management, because almost all of the CCAD has an allergy, especially for house dust mite. And usually we also use the off-label steroid irrigation. There is no guidelines for off-label steroid irrigation, but there are several positions. What kind of position give the best result? According to systematic review, that Meegan position and Regan position is the best for the low volume, for example, 2 milliliter or 60 milliliter. But for what 90 degree is the best position for high volume steroid irrigations. And if there is no improvement, then we can perform the surgery. Slide. And the surgical techniques is ethmoidectomy and also sculpting the polypoid changes in the superior septum or the medial wall of the middle turbinate to facilitate the irrigation optimally. Slide. This is non-type 2 CRS. Usually patient patient came with purulent secretions in both sides and nasal obstruction. And after medical treatment for 6 until 12 weeks, then we perform the CT scan. There is no improvement. Then we can perform the surgery. But the surgery is different. The surgery is only for conventional surgery with not necessary to perform the extend surgery or wide open cavity. And usually the result is quite good. Slide lagi. jarang sekali memberikan kekambuhan yang mukosa is healthy dan video dipercepat kita we can see that open cavity improvement of the symptom of the patients. We can see that in this technique mucosal sparing phase we can see that the frontal sinus is also open. Percepat videonya. Oke. This is a secondary, balik sebelumnya. Secondary rhinosinusitis. In localized secondary rhinosinusitis, such as odontogenic fungus ball, tumor, or polyp anthracoanal, is direct surgical cases. So we don't necessary to give the appropriate medical treatment before surgery. We can directly ask for CT scan and perform the surgery. And slide. This is example for slide lagi. Odontogenic rhinosinusitis. Usually patient came with slide lagi. Patient came with unilateral symptom and nasal obstruction, rhinorrhea, and foul odor or bad smell secretions, and also a history of dental infection or dental treatment. Slide. There is a guidelines, Professor Bang Yujun suggests that we can, when the patient came unilateral suspicion of odontogenic, we can consult to dentist while we can give medical treatment or minimal 2 weeks, and then if they fail, then we can perform a surgery. Depends on each cases. Slide. But in some cases of odontogenic rhinosinusitis, there is a bulky or bulging uncinate process. This is one of my patients with foul odor, smell, bad smell, secretion, postnasal drip, and we can see there is a bulging of the uncinate process. And according to my experience, and also from the literature, that bulging or bulky of the uncinate process is a predictor that patient might not respond with medical treatment, and we can perform the surgery. Slide. This is a study from Professor Winjun that bulky or bulging of the uncinate process have a good predictor for us not respond for the medical treatment. Slide. Sometimes we have difficulty in diagnosing odontogenic because maybe when patient with dental filling, slide, patient, we consult to dentist, then they said, oh, it's okay, dental filling is no problem. But we have to remember that some fungus ball also could occur for patient who has dental filling using the zinc oxide. Slide. Zinc oxide of dental filling could contribute to the fungus ball formation. Slide. So that in some cases, ketika dokter gigi berkata tidak, tambahan giginya oke, tidak ada masalah, maka kita perlu melakukan CT scan. And sometimes I collaborate with my colleague radiologist to modify the position of paranasal CT scan. Slide mundur. In oblique sagittal reconstruction. This position could see where the dental detail posterior maxillary teeth and detail assessment apices maxillary molar and molar, detail alveolar process, and detail overlying floor of the maxillary sinus. So even though the dental filling is intact, but we can see there is a perforation of the membrane Reisner, and probably it could also be caused by the dental filling. Slide. Okay, maxillary fungus balls, usually you can see there is a unilateral homogeneous with calcification or hyperattenuations, and when the intraoperatively can see the cheesy mass-like. Slide. Okay, slide. Okay, slide. Yes, in some cases, I have found one cases with recurrent fungus ball after surgery. The patient referred to other hospital and already performed the undergone the surgery with wide open maxilla, and the fungus ball is recur. It made me wonder what happens, why the fungus ball is still recur. There is two possibility: incomplete surgery, or there might be already defect of mucociliary clearance. Slide. Slide. Yeah, recurrent fungus. Yes, but Professor Richard Harvey said that some cases with recurrent fungus ball after wide maxillary anthrostomy that might be because of the defect of the mucociliary clearance that he called it upper airway bronchiectasis, and he suggests to perform the surgery that avoid some effect. Some from the English dictionary is sumur pompa. Jadi ketika kita melakukan giant anthrostomy, terdapat lantai dari sinus maksila membentuk sumur, dan ketika terjadi gangguan, the fact on mucociliary clearance, the fungus ball cannot clean by the ciliary clearance. That he suggests to perform modified medial maxillectomy, endoscopy, then we cut the posterior end of the inferior turbinates. So we allow the nasal irrigation replace the mucociliary clearance in the maxillary sinus. Slide. This is one of sphenoid fungus ball. I opened and clean it up with mucosal preservations, and also lower the ostium. But we have to be very careful because there is a posterior nasal artery in the lower ostium. This patient also came with severe headache and diplopia. So with patient with fungus ball, no need to wait. We have to perform the surgery immediately. Slide. And secondary with diffuse, there is a PCD, cystic fibrosis. One of the slide is hereditary recessive gen defect. For example, primary ciliary dyskinesia, with usually accompanied with chronic otitis media, situs inversus, and usually this because the defect of motility cilia. It's almost the same with cystic fibrosis, but with different pathophysiology. In cystic fibrosis, there is defect on slide. Okay, different pathophysiology. Fortunately, is a rare case in our country, but in Cipto Mangunkusumo Hospital, there is already in the pediatric division already sweat tests already available, so we can make a diagnosis of cystic fibrations. So and the diffuse like Wegener granulomatosis and others very seldom in our country because it's dominantly in the Caucasians race. Okay, a good surgeon is also a good physician. This is one of my favorite quotation from Professor Daniel Simmons. As a surgeon, as a rhinologist or as ENT doctor, we not only need to improve our skill surgery, but also understanding a basic pathophysiology each of the patient, because there's so many variant of rhinosinusitis which maybe need a different appropriate medical treatment and need different surgical techniques. So elaboration endotype offers new possibility in terms of prediction, prognosis, and risk. We can sophisticated guide and personalized pharmacotherapy, personalized surgical approach, and prevent irrational expectation from the patient, and collaboration with patient for long-term treatment. As Prof. Jafir said, that we have to listen to the patient, maybe for life, for the lifetime our life, because for example, intractable cases, maybe they will always came with recurrence. We have to listen them and make a good bonding with our patients. Slide. Precision medicine concept. For especially in difficult case rhinosinusitis, we have to collect a piece by pieces of puzzle to lead us to memberikan potongan-potongan yang utuh untuk melihat bahwa ini suatu diagnosis yang tepat, sehingga kita bisa memilih tata laksana yang tepat untuk masing-masing pasien. Kapan kita harus melakukan konservatif terlebih dahulu dengan medical treatment, dan kapan kita perlu melakukan operasi segera. Slide. Dan dengan which seeing our patient with good improvement symptom and good mucosa, healthy mucosa is something for a doctor is something money cannot buy. Not only patient could happy, but also the doctor would happily ever after. Thank you very much.